Okay, yeah, we're back live again, and thanks a lot. I think if you can, give me a second. Okay, yeah, we're back live again, and just to go. Thanks a lot. Okay. So live again. So I have to say this again. So I have to close. I have to close one Zoom and then close the YouTube. So it makes a bit of a mess. So I'd like to introduce Professor MATEJ Stuhec, who is a psychiatric clinical pharmacologist, and he works at the Department of the Psychiatry in the University of Maribor, and it's the Department of Clinical Pharmacology, and it's the almost Psychiatric hospital, which is possibly in a beautiful place in Slovenia. So I hope this is working, and we will try to get everything recorded, what you're saying.
Thank you very much, Rainer.
Okay, so we're recording now. Okay.
So
Please.
Thank you very much for this participation. I will talk today about a very interesting and useful topic, a gap between evidence-based pharmacotherapy and actually clinical pharmacology in patients with schizophrenia treated with antipsychotic. And hello, everyone. I'm from Slovenia, actually from one of the smallest European countries, and it is located in the middle of Europe between Venice, Vienna, Zagreb, and Budapest. And now here is my disclosure slide. But actually, I have no personal affiliation in context to this lecture. And here is something about myself. Actually, Reinhard explained me already. I'm included in European Psychiatric associations for many years. And actually, I'm a psychiatric clinical pharmacist. I work in daily practice in my hospital pharmacy and also in primary care settings. So I will present you some very interesting data about multidisciplinary approach already mentioned by Daria before. And here is my outline. First, I will tell something about some basic facts on this topic. Then I will open the second points, actually evidence-based trials and the real clinical practice trials. And then the third point will be a gap between research and practice, actually what we have and what tools we have to improve medication use in this special population, and of course, summary and recommendations with take-home messages. And now for the background, we know that schizophrenia is a long-term, actually antipsychotic treatment, and that evidence-based pharmacotherapy supports use of well-designed meta-analysis and randomized controlled trials in establishing treatment guidelines. But unfortunately, long-term effects are often not available in those papers. And schizophrenia includes early onset patients and also the late onset patients, which are in many cases underestimated, but they account actually from 15 to 20% of all cases with schizophrenia. And we know that up to 50% of patients do not adhere to their treatment, and approximately 75 of them experience recurrent relapse. And total polypharmacy is very common in this population, so it's usually a rule than an exception. And adverse events are very frequent especially because of side effects. And actually, how useful are then standardized mean difference, number needed to treat, number needed to harms values in real clinical practice? Not so, unfortunately. And although it would be very easy, there are still many problems with the medication use and selection in daily practice, which can lead to the treatment failures, medication or medical errors and harms in this special vulnerable population. And now I go ahead. This is now my second point. First, we have different treatment guidelines for schizophrenia treatment from American guidelines, European guidelines, Port guidelines, and NICE guidelines. But all of them are very similar, that for the first line treatment, for the first episode patients, usually second generation antipsychotics are recommended in monotherapy treatment. Then as a second line treatment, it's again very similar, another second generation antipsychotics or even clozapine according to the some guidelines. And the third line treatment, always actually clozapine. Fourth line treatment, clozapine augmentation. And NICE guidelines are quite more specific because they recommend check therapeutic drug monitoring of clozapine before adding a second antipsychotics, and always check side effects, which is very important because sometimes if we do not have, for example, appropriate plasma levels, then it's very useless to add another antipsychotic. And then the fifth line treatment, like some another treatment strategies. And now when we are talking about the evidence-based trials, including well-known meta-analysis, first one was published in 2013 by Professor Lloyd and co-author in the Lancet, actually 10 years ago. And they check treatment efficacies among different antipsychotic treatments. And actually they found that antipsychotics differ substantially in side effects only, but small but robust differences were seen only in efficacy. So actually the mean age of trial participant was 38 years. And the next meta-analysis, which included mostly elderly patients with schizophrenia, was published by Krause and co-authors in 2018. And they actually found only 18 trials, including elderly patients with schizophrenia, which is a pity because we have many patients in a real clinical practice, and definition of elderly was very heterogeneous across the studies, which is another very important limitation. And only 3 of 18 included studies included patients with a minimum age of 65. So we have very few data, especially in the elderly patients treated with antipsychotics for schizophrenia treatment. And the mean trial duration in the meta-analysis was only 10 weeks, and the patient with polypharmacy were again excluded. And now, in the first mentioned meta-analysis published by Lloyd and co-authors, they checked antipsychotic efficacies among different studies, and clozapine was the most effective antipsychotic, followed by amisulpride, olanzapine, risperidone, paliperidone, and so on. Very interesting that only clozapine was actually more effective than other medications, and most of the other antipsychotics were very similar in their efficacies, including their number needed to treat, a standardized mean difference, which was actually approximately 0.5, which means that number needed to treat is approximately 7 to 10. And very interesting that this meta-analysis did not include chronic, so the treatment-resistant and chronic patients. But anyway, clozapine was the most effective medication in terms of treatment efficacy compared to placebo. It means that maybe we, in the near future, we should modify treatment guidelines and put clozapine after first antipsychotic treatment, not after the second one, as we can see in the most guidelines. And when we are talking about some other important facts like all-cause discontinuation, which is actually associated with both treatment efficacy and treatment tolerability, and amisulpride was the best in this point of view, followed by olanzapine, clozapine, paliperidone, and risperidone. And from these results, it's very clear that amisulpride is very optimistic and very good medication in terms of efficacy and tolerability, and is under-consumed in many European and worldwide countries. And then when we are talking about side effects, I will mention a little bit in the future, but anyway, very interesting that the PINs were mostly associated with a weight gain, which is also very important for medication selection. Anyway, very positive outcomes, but no data in this meta-analysis on the long-term tolerability, include diabetes, stroke, and deaths, which are sometimes associated with the long-term treatment. And now, when we are moving from the general population to the elderly patients treated with antipsychotics, in elderly patients, olanzapine was significantly superior compared to haloperidol, and actually very small sample size study, and number needed to treat was very similar like in the general population. And in another study, they showed that paliperidone was even not more effective than placebo, which is quite surprisingly because it's very common used medication. And for a negative symptom, olanzapine was significantly superior compared to placebo, and number needed to treat was again approximately 8. And when they check depressive and positive symptoms, actually no difference among different antipsychotics compared to other antipsychotics and placebo. And in terms of dropouts, due to any reason, actually olanzapine was significantly better accepted compared to risperidone. And now, what's next? In the next meta-analysis published by Professor Hoon and co-authors in Lancet 2019, they actually included a little bit more real patients because it was a systematic review and network meta-analysis, including multi-episode schizophrenia patients, which are quite more common in the real clinical practice, like patients included in the previous mentioned meta-analysis. And in terms of the overall change of symptoms, actually clozapine was against more effective than placebo, and standardized mean difference was 0.9, which means that number needed to treat is quite higher, approximately 4 to 6, followed by amisulpride again, then zotapine, olanzapine, and some other antipsychotics. And from this picture is very clear again that clozapine maybe should be used a little bit earlier in the treatment guidelines compared to other antipsychotics. And very interesting that some antipsychotics were actually not more effective than placebo in randomized controlled trials. We have some reasons. Some of them were included, but they have very long half-lives, and we should wait in the real clinical practice a little bit more than 4 to 6 weeks. For example, some newest antipsychotics on the market, like cariprazine, for example, which was also included, but standardized mean difference is very small, just 0.3, which means that number needed to treat is approximately from 10 to 20, and there is a question of clinical significance. And when we are talking about positive symptoms, amisulpride was the most effective medication compared to placebo, and other antipsychotics compared to placebo, and number needed to treat was again approximately 7, followed by risperidone, clozapine, olanzapine, paliperidone, and so on. Some of the antipsychotics were again not more effective than placebos. And now, in terms of negative symptoms, which are very difficult for the treatment, and we have just few medications on the market, for which we actually have good studies that they are more effective than placebo. In this meta-analysis, clozapine was again first-line treatment, followed by zotapine, amisulpride, olanzapine, asenapine, and so on. And some of the antipsychotics, including, for example, zuclopentixol, were not more effective compared to placebo. And in terms of depressive symptoms, which are actually commonly seen together with schizophrenia treatment, sulpride, clozapine, amisulpride, and olanzapine were actually the most effective medications, again, compared to placebo. And sulpride and clozapine, actually, they had a very, very high standardized mean difference, especially sulpride and amisulpride, which is very similar medication. And that's why, we have a good data to use in these comorbidities. And the most of antipsychotics, again, did not show any benefit effects compared to placebo in patients with depressive symptoms with schizophrenia. And now, when we are moving from efficacy trials, which are quite useful in clinical practice, because the most patients are comorbid patients, the most of them, they are treated with polypharmacy and co-medications, and that's why effectiveness trial are much more representative for the real clinical patients. And first, I just want to go briefly through the ELFES study, which included first schizophrenic patients and with actually quite a minimum selection criteria. And very interesting that that olanzapine, for example, was better compared to some other antipsychotics. And it's very clear that actually the results from all studies indicate that differences in effectiveness and tolerability do exist between antipsychotics. And very interesting that approximately 60% of schizophrenic patients actually remitted. And when we are moving to the case study, which actually included especially chronic patients, with co-medications, which is very important because we see in the clinical practice very similar patients. And very interesting, again, that chronic patients, they had a quite poorer clinical outcomes compared to the first schizophrenic patients for approximately 30%. And it means that we should treat patients as early as possible to avoid, chronic episodes. And now, when we are going through the alpha study a little bit more briefly, first on my left slide, I have a proportion of patients with 50 to 100% of response. And here on this X, I have time in months of the treatment. And when they compare different antipsychotics along different treatments, it is very clear that amisulpride and olanzapine, they were more effective compared to haloperidol. And it is another idea why haloperidol should not be a first-line treatment in schizophrenia treatment. And when we are comparing proportion patient with remission, we have very similar results. Amisulpride, olanzapine were against much more effective than some another medications, including ziprasidone, quetiapine, and haloperidol. And now I want to show you another new study, including Finnish and Swedish cohort studies. And very nice study was published by Jari Tihonen and co-authors in the JAMA Psychiatry 2019, where actually they included the real patients from the real clinical life from actually Finnish registry, and they included inpatient patient during 75 to 2014 in Finland, and actually included all cohort of all persons with schizophrenia. So they put together all patients with schizophrenia in the registry, and actually hospitalizations were the primary outcome measures, and they checked the outcomes between patients treated with antipsychotics and patients treated without antipsychotics. And actually the median age was 45 years. So it means that also elderly patients with schizophrenia, some of them were included. And the median time was 14 years actually, and a little bit less in the incidence control. And when we are talking about the prevalent control, so non-first schizophrenic patients, it's very clear that in terms of psychiatric rehospitalization during specific treatment, compared with non-antipsychotic use, almost all antipsychotics were more effective than no treatment. So it is very clear that antipsychotic treatment can lead to the better clinical outcomes in terms of psychiatric rehospitalizations compared to non-antipsychotic treatment. And what were the differences? Especially clozapine and aripiprazole was better for 58% compared to non-treatment, followed by any long antipsychotics and olanzapine and so on. And clozapine monotherapy was very highly ranked as a fourth line treatment in terms of psychiatric hospitalizations, followed by some other combinations and monotherapies. And very interesting that the lowest risk of hospitalization was observed for clozapine plus aripiprazole, polypharmacy being for approximately 40% lower than for clozapine. And it means after clozapine, unsuccessful treatment maybe or non-remission, it is a quite good option to use together with the aripiprazole. And now the hazards for all-cause hospitalization was approximately 10% lower for treatment compared to non-treatment, included that for 24% lower hazards compared to non-treatment. And very interesting that the mean clozapine dose was approximately 426 milligrams during monotherapy and approximately 400 during polypharmacy, which means that in polypharmacy patients, actually clozapine dose was a little bit lower compared to monotherapy. And now, actually, it is now a very interesting question. There is a, clinical significance if you use polypharmacy or monotherapy. According to these results, there is just a few difference in terms of polypharmacy compared to monotherapy. So it's always a clinical important question. And again, if number needed to treat are approximately 10 to 20, it means that the absolute difference is approximately less than 5%, as it's always a question of clinical meaningful. And now we have many limitations in this cohort study. For example, selection bias is always very important, no randomization design within design study. Then the few data about co-medications, DDIs, so the drug-drug interactions and adverse events. And we know that older adults actually, they have more DDIs, more medications, more comorbidities. So actually, few data on comorbidity, statistics always COX regression, we have limitation of COX regression also. Very few effect size for polypharmacy use instead of monotherapy actually, and different number of patients in each group, which actually can have an impact on the confidence intervals. And now in the next cohort study published by some of the same authors like Heidi Taipala and co-authors in schizophrenia research, they actually checked an impact of different treatment strategy, including antipsychotics compared to no treatment in terms of overall mortality. And it is very clear that if we treat patients with a first generation oral antipsychotics, there is approximately 25% difference, followed by second generation oral antipsychotics compared to no treatment. There is a 42% difference, followed by a third generation long-acting for 48%, and second generation long-acting antipsychotic for 62%. So this is a very important message for our patients that if they are treated, they can expect much more better clinical outcomes compared to non-treatment as a long-term treatment for schizophrenia. And now, when they actually follow patients for 20 years in again in a Finnish cohort study, and they check the consequences as a long-term treatment in a 20 years of treatment duration, they actually check survival probability of different treatment strategy. And it's very clear that antipsychotic treatment actually can lead to the better survival probability compared to non-antipsychotic treatment. And the cumulative mortality rates during maximum follow-up of 20 years were 46% for non-antipsychotic use, 26% for any antipsychotic, and be very careful, only 16% for clozapine use. So, we have a very good data as a long-term data for clozapine use, which should be used very early in the schizophrenia treatment. And this study shows that clozapine is very effective and quite well in tolerability aspect as a long-term treatment. And what we have now, when we move a little bit to the clinical pharmacology, now we have some new medications on the market, like the partial agonists, like cariprazine, for example. And we have a much more studies which are associated with a mesocortical pathway and some antipsychotics, including cariprazine, with its D3 agonist activity, which can lead to the better clinical outcomes, especially important for the negative symptoms. And now, when they compared actually patients with a stable schizophrenia on more than 2 years, they actually randomized them to cariprazine or either risperidone with a 1-to-1 ratio randomization. And they have included approximately 500 patients. And very interesting that after 26 months of the study, cariprazine was more effective than risperidone, and number needed to treat was 8, standardized mean difference from 0.3 to 0.5, which means that we have a actually study including schizophrenia, predominantly negative symptom patients, that one antipsychotic was actually more effective than another antipsychotic. This is a very big problem in psychopharmacology and psychopharmacological trials, because the most of the antipsychotics they have actually similar efficacies, and it's very difficult to show that one antipsychotic is better compared to other antipsychotic in a head-to-head trial, and that's why we have problem with reimbursement in many countries, because the reimbursement agency they want actually effectiveness trials, and they want benefits also in terms of efficacy, not just the similar efficacy. And that's why we should think what we will do in the real clinical pharmacological trials in the real future if we want to have more and more antipsychotics, because we are not so successful as compared, for example, alcoholics in the general medicine and cancer medicine, where actually they have every day more than 5 or 10 new medications on the market. And now, what's next? We have in the real clinical practice, especially in the elderly patients, in those trials, actually, we have a few data on polypharmacy, long-term tolerability, and drug-drug interactions. Keep in mind that about half of the old patients are treated with polypharmacy, and the patient with schizophrenia are treated more than 6 to 10 weeks. So actually, randomized trials are not so representative for the real population, and only 50% or even less percent from the real clinical practice are maybe suitable for the randomized trials, which is another very huge limitation when we use the guidelines only from the randomized trials for daily use. And now many adverse events occur after more months, for example, if the patients are being treated with olanzapine, for example, which has many problems as the weight gains after many months or year even, you can expect very serious adverse events. So actually, those patients are often excluded from the treatment guidelines, well-designed randomized trials and meta-analyses. And actually, are those papers enough to teach psychopharmacology? And I think it's a very important question. And that's why we need a little bit more clinically oriented guidelines, including different trials, non-randomized trials, and also cohort trials. And now, what gaps we actually have? First, if we use antipsychotics, actually we can expect more drug-drug interactions with the other medications, like for example antibiotics, as we have shown in one Slovenian national study that approximately 30% of DDIs in nursing homes were associated with antipsychotics. And if we have more DDIs, then we can expect more problems, more adverse drug reactions. And then clozapine is used very late in many countries because antipsychotic polypharmacy is used before in many countries, which is a pity. And polypharmacy is rather a rule than exception in older adults. Polypharmacy is not always bad story, as is seen in some media, and also from the patient perspectives, they have many questions about polypharmacy. But sometimes we should use polypharmacy, but when we can avoid, it's better to do it. And now this is one of my real clinical challenge from daily practice. I have actually my grandpa in my Slovenia nursing home, as I'm also a clinical pharmacist consultant in this nursing home. My colleague, psychiatrist, and another colleague, GP, they send this patient to me to make a medication review. And actually, patient was treated with quetiapine 300 milligrams for quite old, I would say, late onset schizophrenia, and many other comorbidities like diabetes, for example, with gliclazide, metformin, then statin, of course, together, and depressive symptom, and then also blood pressure and urinary tract infection. That's why ciprofloxacin was added by his GP 2 days ago. And actually, we have many questions, many real questions. Which medication for depressive symptoms first, and then which medication for diabetes, which medication for the elevated blood pressure, and what we do with quetiapine. First, actually, I suggested to titrate a little bit up of trazodone, and then what to add another medication for diabetes, some newest medication on the market, which are far more acceptable in the patient with schizophrenia, like for example, some some very old medication for diabetes, like sulfonylureas, for example, and so on. And then what's next? We have DDI here, like ciprofloxacin is contraindicated together with tizanidine, and ciprofloxacin use can lead to some problems like delusions, hallucinations. So we should be very careful which antibiotic we use in the elderly patients on schizophrenia to avoid additional problems with delusions and hallucinations. And that's why penicillins are the most recommended. And now what's next? We can move from polypharmacy to monotherapy, and we have some studies on the volt level. In the first study, they switch stable chronic patients to either monotherapy or stay on polypharmacy, and it was no statistically significant difference after 6 months. And very interesting that when they checked the adverse drug reactions, especially some side effects like the body mass index, it was statistically significant difference, which actually show that if we use polypharmacy, we can expect more weight gain, which is not good for our patients as a long-term treatment. And now, what next we have? Approximately 50% of patients with schizophrenia do not adhere to treatment in a short-term treatment, and clozapine is used very late in many countries because antipsychotic polypharmacy is used before in 30 to 40 patients, and 60% are non-responders in the treatment-resistant schizophrenia. And prior to clozapine, as was studied, very interesting study by Kane and co-authors. Actually, they showed that prior to clozapine, 3 to 5 different antipsychotics were used, and very high doses antipsychotics like haloperidol, risperidone, much more over the label dose, and that in 10% to 34% polypharmacy was used, and actually clozapine delay was mentioned like 4 to 10 years. So the non-responders to clozapine treatment will respond only to clozapine. This is very interesting because not the higher dose, not the antipsychotic polypharmacy, not the longer trials are recommended. And now clozapine has an approved medication for the treatment-resistant schizophrenia. And we know that delay initiating clozapine is associated with a lower response rate. This is very important message. And we can use clozapine clinics, protocols, and share prescribing protocols and educational guidelines. For example, in my setting, I'm included in this protocol. I, as a clinical pharmacist, I monitor patients. I educate patients about a healthy life when they are on clozapine. I educate them, about recreation, how they start to do it, with sport, about the diet, and so on. And it's very important that we do together this business. And now, if we go ahead, each hospitalization means that 4 to 8% we can expect lower clozapine efficacy. So do not lose clozapine. And each new antipsychotic is instead of clozapine after second unsuccessful treatment with any antipsychotic means 8 to 11% of lower clozapine treatment efficacy. And doses 200 to 450 milligrams are recommended, not more than 550. And slow titration is very necessary to avoid some medication-related problems like hypersalivation, then insomnia, weight gain, QT prolongation, and so on. And now what we can do, what's next when we have a clozapine-resistant patients, usually we can use augmentation strategies. We have some data in combination with other antipsychotics like aripiprazole, amisulpride, for example, when we combine 2 different types of antipsychotics. But be very careful when you combine amisulpride and clozapine. Always check QTc prolongation, heart rhythm, then blood pressure, and so on. And so avoid this combination in patients with already presented cardiovascular problems. Then we can use we have some data with mood stabilizer and some another treatment strategies like lamotrigine, for example, electroconvulsive therapy, and so on. And now, long-term treatment, keep in mind that actually we have some dose and non-dose dependent events, especially side effects associated with antipsychotics. And we have a few trials about dose comparison, which is also a pity, and it would be necessary for a real clinical practice. And then we have few long-term trials about combination treatment. And then co-medication and adverse events and QT prolongations and so on. And that's why always check problems and the anticholinergic burden, which is very problematic in the elderly patients. So you can use the calculators like anticholinergic calculator scale, which is very useful in the clinical practice, and always check co-medications. And now, when we are talking about tolerability concerns, we usually select antipsychotics on their tolerability, especially on weight gain. So the pains are quite bad in this point of view. Then EPS, especially in the elderly patients, haloperidol is not recommended. Then again, QTc prolongation. This is very important aspect because we have a lot of patients with other medications and some other medications like antiarrhythmics, like antibiotics, like, for example, ciprofloxacin, and antidepressants like escitalopram, trazodone, can even prolong QT, and that's why you can expect even more problems. So that's why it's very useful to select antipsychotics with a low chance for the QT prolongation, like luridone, for example, aripiprazole, paliperidone, and so on. Then we have very similar story when we are talking about sedation, which is very similar like weight gain, because we have more or less similar receptors. And now what we can do, actually monitoring is necessary, otherwise we can lose the patients and they will drop out actually because of the poor medication adherence, which is often seen in clinical practice. First, we can provide charts, like, for example, flow charts for all patients at each visit. Then we can check weight gain, fasting, triglyceride and glucose level, and the blood pressure. And that's why we can monitor patients and we can see what is going on. If we have problems there, we can add other medications, or if we have a treatment relapse, then we can switch to other medications. So that is very important highway from, especially we should be very careful at the beginning to protect patients from especially diabetes and higher mortality rate. And now, what is very important when we are talking in the real clinical patients, that comorbidities in schizophrenia, actually comorbidities are very high, and that's why we know that comorbidities are associated with a higher risk for death in those patients, and that cardiovascular diseases are the most often associated with deaths in patients with schizophrenia, followed by acute lower respiratory infections and other infections. And cardiovascular diseases are responsible for approximately 20% of reduction of life expectancy compared to the general population, especially diabetes, cigarette smoking, dyslipidemia, hypertension represent the main risk factor for death. And keep in mind, my dear colleagues, that inadequate screening for metabolic problems is evident in a real clinical practice, that only 25% and 10% of patients initiating second-generation antipsychotics are screened for glucose and lipid abnormalities. So this is important to expand our business here, to collaborate to each other, and to avoid patients from the serious metabolic problems. And now, together with my colleagues, Professor Bitter and Professor Moore from European Psychiatric Association, we have published very interesting chapter, including some strategies, what we can do in a real clinical practice when we can expect problems or when we already have problems. For example, when we have a metabolic effects associated with antipsychotics, they are usually, most of them, we have a dose dependency. And the first hint is regular monitoring. Always regular monitoring, provide the charts. Their non-pharmacological interventions are necessary, like diet, physical activity, So we should make a plan for our patients and then switch to low-risk antipsychotic in persistent symptoms. Like partial dopamine agonist, we have lurasidone, for example, which is also very optimistic medication in this point of view. And again, avoid antipsychotic polypharmacy, which was associated with more metabolic problems compared to monotherapy. And then if we have problem, treat the patients like for your diabetes, start with metformin, which is a first-line treatment, 2 times 500 milligrams. Then check after 6 to 12 weeks, check glycated hemoglobin. If still you have problems, then add another medications and so on. For endocrine effects, we also have some recommendations. Partial dopamine agonists are recommended, for example, as an adjunctive medication. And now cardiovascular effects, if you have like hypotension, QTc elevation, and so on, always monitoring. Then switch to the partial dopamine agonist or lurasidone in the cases of the QTc prolongations. And then it's very common hematological effect, especially associated with clozapine, and then neuroleptic malignant syndrome, which is not dose dependent. This is very important. This is idiosyncratic reaction, which can happen even in the small doses of some antipsychotics. And we have also some strategies, including antipsychotic with the low D2 potency. And now, again, I have found some studies in which they compared antipsychotic polypharmacy to monotherapy in terms of the incidence of the metabolic syndromes and some other problems. And it's very clear that antipsychotic polypharmacy is associated with a more metabolic syndromes compared to monotherapy. And there is very similar story for diabetes. And long-term observational studies are actually needed. And now what we can use some papers, some recommendations from the real perspectives. This is one of my paper published in the Current Psychiatry Opinion, which is actually a very interesting journal, which is edited by Professor Sartorius. And I have summarized some hints for the daily practice when we have the patients on more polypharmacy. It means when we have patients on 5 or more medications and the elderly patients on schizophrenia, what we can do. First, we have some tools to use in the daily practice to avoid some additional medication-related problems, but very interesting that approximately 50% of the elderly patients, they use antipsychotics without approved indication. I mean, not for schizophrenia, but for other problems like behavioral problems of dementia and so on. And now, when we are talking about the gaps, we should talk about the pharmacokinetic aspects like for example, absorption, then metabolism, distribution, elimination. And keep in mind, my dear colleagues, where you want to have an effect, you should have medication of the site of action. It means you should have medication in the central nervous system. So that's why you have some problem with the inflammation, for example. If you have some problem with the comorbidities, co-medications, kidney failure, then the elevated liver enzymes, then you cannot expect a medication of the site of action, for example, and you cannot expect an effect. So that's why we have many complications, in the clinical practice, which are important for medication selection. And now, keep in mind that always we should have medication in the steady state. It means after half-life, usually. It means like 1 to 3 to 6, even 10 weeks. Depends on antipsychotics. For example, cariprazine has very long half-life and active metabolite. And that's why you should expect a little bit more, like, for example, 2 months even in some patients. So you should be very careful which antipsychotic you select and wait until the steady state, and then you can expect an effect. And now, next, we have different pharmacological profiles on different antipsychotics. And except of clozapine, we know they are very similar in their treatment efficacy and maybe effectiveness. And that's why we make our medication selection on possible side effects, on comorbidities. And that's why we can check with the charts, like these charts, when we have a receptor affinities toward different receptor associated with different antipsychotics. And for example, if we have constipation, we have and olanzapine, which is quite often because olanzapine has very high affinity towards cholinergic receptors. And when we change the patient, for example, switch patient from olanzapine to risperidone, which has very few affinity toward the M1 cholinergic receptor, and that's why it's quite more safer medication for example, for those effects and so on. And what's next? What was shown that actually previous work indicating that treatment intensity is associated with the brain tissue loss, very important. They suggest that clinicians should strive to use the lowest possible dosage to control symptoms. And on another side, because they also indicate that relapse is associated with brain tissue loss, they confirm the importance of relapse prevention in schizophrenia. And what's next? The duration of untreated psychosis is also positively associated with a poor outcome. So treat the patients as early as possible. And now when they actually compare different thresholds for clinical responses to occupancies of dopamine D2 and serotonin 5-HT2 receptors for haloperidol, olanzapine, and risperidone, it is very interesting that if we look to haloperidol picture, if we use 2 milligrams, for example, daily of haloperidol, we can expect D2 receptor occupancy of like 70%, which should be enough for schizophrenia treatment. If we use then 5 or more percent, then we can expect EPS, as a consequence of the D2 blockade. And if we move towards olanzapine, for example, there is very clear that we should use a little bit higher doses for schizophrenia treatment, like, for example, 10 to 20 milligrams, because with 20 milligrams, we can expect approximately 75% of receptor occupancy. And compared to risperidone, it is opposite story, because risperidone has very negative therapeutic index in this point of view. It means that if we use, for example, 2 milligrams, it's maybe not enough. Then if we use 4 to 6 milligrams, we can expect EPS. So it's very tiny line among treatment occupancy and the EPS in terms of risperidone. That's why you should be very careful when you titrate risperidone. Use very, very, very slow titration to avoid EPS in those patients. So it's very clear that there is necessary approximately 60 to 70% of D2 treatment occupancy in the most antipsychotics for treatment effect. And now, what's next? We have some pharmacological consideration in patients on antipsychotics. Usually, when we are checking drug absorption, always check how patients actually are taking medications and how medications are being administered by nurses, for example, in hospital. Because if you use quetiapine sustained release form, haloperidol, ziprasidone, for example, especially if you use quetiapine haloperidol by food, then you can expect for 30 to 50% of the lower plasma level, which is not a good scenario, because you should titrate up of haloperidol, and then you can expect EPS and interactions in the gut, for example, which is a quite bad scenario. So always check how the patients actually are taking medications. And drug metabolism, avoid use medication with many potential DDIs, like carbamazepine, for example, like paroxetine, fluoxetine, for example, and so on. And if we check in terms of antipsychotics, sulpride, amisulpride, paliperidol, they have a very few potential for drug-drug interactions. And now for drug elimination, always check the kidney function. If you have problems, then use quetiapine, paliperidone, for example. When you have elevated liver enzymes, then use sulpride, amisulpride, and paliperidone, especially sulpride and amisulpride. They are very interesting medications because they are quite underestimated and underused in the most European countries. But they have some positive effects. for example, when you have patient on polypharmacy and you have many different medications, because the cytochrome enzymes, they have not any impact on the amisulpride metabolism, which is very positive in pharmacotherapy selection. And when we are talking about elderly patients, especially avoid to use tricyclics, antitricyclics like amitriptylines, like phenothiazines, antipsychotics, and so on. And we also have conducted one interesting study in Slovenian primary care settings where we included different elderly patients with different mental health problems on polypharmacy. And we have provided medication review by clinical pharmacists, and we have checked the consequences. And very interesting that the number of potential inappropriate medications dropped down significantly for approximately 50%, and approximately the number of medications also reduced for 20%. And when we check actually treatment guidelines adherence in schizophrenia treatment actually improved for 20%, which means that collaboration is quite beneficial for all patients, especially when they have a huge or excessive polypharmacy, 5 to 10 medications concomitantly. And now here's my case. I work also in primary care settings in the GP offices in Slovenia, which is reimbursed from 2018 in Slovenia. So now we have a good collaboration with the GPs and psychiatrists and other healthcare professionals on different medication classes, especially when we have patients on polypharmacy. And now here is my summary. Dear colleagues, long-term antipsychotic use actually does not increase severe physical morbidity, leading to hospitalization, and is associated with substantially decreased mortality. This is very important to keep the patient in remission, not to lose the remission first. And then hazard for psychiatric hospitalization was actually approximately 7% lower during any polypharmacy compared to monotherapy, which is just very, very small difference. And we have some data that, for example, low-dose amisulpride was effective and well tolerated as a treatment for very late onset schizophrenia, like psychosis, and olanzapine was the most effective than others in meta-analysis, except clozapine, of course. But there is a huge gap between evidence-based research and clinical pharmacology still in daily practice in patients with schizophrenia. And this is especially evident in the older adults because DDI's polypharmacy comorbidities are excluded, and many patients with schizophrenia treated with antipsychotics have several pharmacological and somatic issues, which emphasize the use of clinical pharmacology in this population. So thank you very much for listening to my presentation. I will finish my presentation with those beautiful Slovenian pictures. So you are kindly invited to come and visit this beautiful diamond in the middle of Europe.
Okay, I'm just, thanks a lot. Are there any questions?